Good morning, class. This is Dr. Weaver, and today we will be discussing care of patients with stomach disorders. Now, if you can remember, as far as your anatomy and physiology is concerned, the stomach is a part of the upper GI system responsible for a large part of the digestive process. Now, some conditions that affect the stomach can be life-threatening. And what many conditions have in common with all the health issues that affect the stomach can impair and alter digestion as well as nutrition. So make sure you do a quick review of your anatomy and physiology of the stomach, nothing too much in depth, because it's always good to do a quick review before you actually endeavor into diseases and disorders, which is the deviation from the norm, of course. So I listed here several objectives so that at the end of this discussion, you should be able to collaborate with the interprofessional team to protect the patient with a stomach disorder from injury and infection. Also, to identify community resources to ensure appropriate transition management for patients with stomach disorders. To also teach adults how to promote GI health and prevent PUD or peptic ulcer disease. And also teach patients with a stomach disorder how to enhance nutrition, promote digestion, and minimize disturbances in comfort. So on this image, I just wanted to show you a picture of a bleeding ulcer on the gastric mucosa, and this is essentially what it looks like. An example of a GI health concern that can occur due to immunity is peptic ulcer disease. Because the mucosa of the stomach and the duodenum's defenses become impaired, and they cannot protect the epithelium from the impact of acids and also pepsin. And of course, the reason we want to fix these patients is we want them to be comfortable and to have good nutrition so that their bodies can be healthy. Essentially, what would happen to our bodies if nutrition is impaired, and this is why this is so important. So peptic ulcer disease occurs when the mucosa defenses become impaired. The epithelium, which is the tissue that is beneath the mucosa, is not protected from the effects of acid and pepsin. Many ulcers are caused by the H. pylori infection, which seems to be transmitted through contaminated food or water. Interpersonal transmission can be a main route of transmission as well. Now, due to bacteria that is now affecting the GI mucosa, an immune response occurs. And as you know, anytime you have an infection, some kind of microorganism in your system, the immune system will begin to mount an attack. In this particular case, cytokines, neutrophils, and other substances are activated and cause epithelial cell necrosis. Essentially, these bacteria produce substances that damage the mucosa. Now, clinicians can use tests to detect H. pylori because the H. pylori breaks down urea into ammonia. And it is this urease that can be detected through different types of laboratory testing. Gastric ulcers usually develop in the antrum of the stomach near acid-secreting mucosa, so that when a break in the mucosa barrier occurs, hydrochloric acid injures the epithelium. Sometimes gastric ulcers occur from back diffusion of acids or dysfunction of the pyloric sphincter, and it is these bile acids that break the integrity of the mucosa barrier, which leads to it does lead to mucosal inflammation and compromise in immunity. So essentially, toxic agents and bile destroys the membranes of the gastric mucosa. Patients with gastric ulcers typically have a delay in gastric emptying, and this causes regurgitation of duodenum contents, which leads to worsening gastric mucosa injury as well. Now, as far as the duodenum, duodenum ulcers usually occur in the upper portion of the duodenum, and they are deep, they are sharply demarcated lesions that penetrate all the way down to the muscle layer, and that is going pretty deep when you think about it. So it's going through the mucosa, through the epithelium, and all the way down to the muscle, and this is how strong these acids can be. Now, a main feature of duodenum ulcers is high gastric acid secretion. The gastric pH is very low or acidic, which is present in the duodenum for long periods of time. Also, protein-rich meals, calcium, and vagus nerve stimulation can bring about more acid secretions. And this combined with hypersecretion resulting from a rapid emptying of food from the stomach will reduce the buffering effect if food is delivered into the duodenum too quickly. Also take a look at stress ulcers as a cause of peptic ulcer disease on page 1108. Which usually occurs after acute medical crisis or trauma, like from trauma or a head injury. So just take a read of that information as well. It's not very long at all. So take a look at these two images depicting favorable conditions that lead to gastric and duodenal ulcers. There's a few items that are actually written about the two effects of this condition. So just take a read of that information when you get a chance. So these are just some of the different types of ulcers I've already discussed with you. So just make sure you're really paying attention to gastric, duodenal, and stress ulcers and how they do differentiate from one another. I will be going into more depth on the next several slides. So unfortunately, there's a lot of information on this particular topic. So I must tell you, it is pretty long. But I will try to make it as painless as possible. Now, when you view this picture, I want you to think about areas of the stomach, including the duodenum, that can be affected. Sometimes these patients may develop a sudden onset of sharp abdominal pain, and when you examine the abdomen by palpation, the abdomen is tense and rigid. When this occurs, you need to notify the healthcare provider immediately. So with peptic ulcer disease, you will see more bleeding with patients who have gastric ulcers or also in older adults. These patients may have a rebleed if their H. pylori infection is not treated properly, or if treatment does not include drugs such as your H2 antagonist. Now, patients with massive bleeding, they usually vomit bright red or coffee ground emesis, and this is known as hematemesis. And this is a condition that occurs when bleeding is above the duodenum jejunal junction or upper GI bleeding. Also, I want you to look at page 1109 and also chart 55-4 for GI bleeding signs and symptoms. When this bleeding occurs below the duodenal jejunal junction point, this blood goes through the digestive process and comes out as occult blood or dark tarry stools, also referred to as melena. So just keep in mind that depending on where the bleeding is occurring, once these patients throw up, the blood would be bright red. And of course, if you see some of these patients when they have a bowel movement and the stools are dark, tarry in nature, then remember that blood has gone through the digestive process. So you get this characteristic tarry stool color, or melena as we also call it. This one develops more, of course, the latter one. It occurs more in your patients with duodenum ulcers. Now, whether a patient has gastric or duodenal ulcers, they can lead to perforation and also bleeding. This perforation occurs when the ulcer becomes so deep until the entire thickness of the stomach and the duodenum is worn away. This would cause contents of the duodenum and the stomach to leak into the peritoneal cavity, and this then results in patients having the characteristic sudden sharp pain in the mid-epigastric region and spreads over the entire abdomen. Now, the classic pain causes the patient to become apprehensive, something you should remember, and the abdomen becomes tender, rigid, board-like in nature. And so now we're dealing with a peritonitis situation, and this is indeed a medical emergency. Otherwise, these patients will die on you. These patients usually will be seen assuming a fetal position in order to decrease tension on abdominal muscles. Now, major complications from these events are bacterial septicemia and hypovolemic shock. So again, this is a medical emergency. Also, what happens is there's a decrease in peristalsis that occurs, as well as these patients develop paralytic ileus as well. Peptic ulcer perforation is a surgical emergency, and again, it is life-threatening for these patients. Also, I would like you to read about pyloric obstruction as a complication of ulcers on page 1109, and just reach out to me if you have any additional questions. As far as intractable disease, ulcer, now this complication develops ulcers when there's excessive stressors in the patient's life, or their inability to adhere to long-term therapy. And of course, these patients are usually referred to a gastroenterologist as a result of their difficulty in healing their ulcers. So we went over this information, but I wanted to make sure you look for these symptoms, because these are certainly things for you to look for. I would like for you to also read page 1110, table 55-2, as it does show how to differentiate gastric versus duodenal ulcers. For example, with hemorrhage, patients with gastric ulcers have hematemesis, more so than melena. But with the duodenum ulcers, these patients will have melena more so than they would hematemesis. So just look at those differences that are noted in the chart. In addition to the symptoms I mentioned, also with auscultation, initially these patients will have hyperactive bowel sounds, but these may diminish with progression of this disorder. Now, dyspepsia is most commonly reported, so keep that in mind. And it is described as a sharp, burning, and gnawing pain. Now, gastric ulcer pain occurs epigastrium in the upper gastrium with localization to the left of the midline and aggravated by food. As far as duodenum ulcer pain, it is usually located in the right of or below the epigastrium, and the pain occurs 90 minutes to possibly 3 hours after eating, and often awakens patients at night time. The pain can be made worse by eating certain foods like tomatoes, hot spices, etc., or taking certain drugs like NSAIDs or steroids as well. As far as assessing for fluid volume deficit, we want to take orthostatic blood pressures and also monitor for signs and symptoms of dehydration with these patients. And also, we want to assess for dizziness, especially when the patient is in an upright position. They will begin to feel dizzy even so. And this can be the result of a volume deficit because they might be bleeding. So on this slide, I just wanted you to be aware that we should always consider the psychosocial impact of disease on your patients, and to just consider, assess the impact of the ulcer disease on the lifestyle, the occupation, their family, social and leisure activities. Can be quite devastating for these patients. And of course, this is when you want to be able to use your therapeutic communication that you're learning from Professor Thode. Lifestyle changes certainly requires health promotion modalities, as stated earlier as well. So as I mentioned to you earlier, as far as diagnostic testing, there is a test where your physician may order, they have a laboratory test that can assess for H. pylori infection. Remember the ammonia that develops as a result of having this bacterial infection. There's also a chest abdominal X-ray series that is done, and this is used to detect if perforation is suspected. There's also an EGD that is performed as well. And also one of the tests I did add was a nuclear medicine test. And this test is performed to assess for suspected GI bleeding. So on this slide, I just wanted to make sure that you consider some nursing considerations. This is very important for your protection. These patients, again, they can vomit large amounts of bright red blood. And so you want to make sure that you are wearing gloves at all times. And also, these patients, they might require an NG tube. These NG tubes can be very uncomfortable. So whenever you can provide some comfort measures, you want to do so. And many of these tasks can be delegated to your unlicensed assistant personnel, especially things like oral care for these patients. So as far as evaluation is concerned, we want to make sure the patient does not have active PUD or complications, that they verbalize pain, control, or relief. Also that they are adhering to drug regimen and any lifestyle changes that were suggested to them. And also does the patient, or that the patient does not experience upper GI bleed. Want you to also read page 1114 through 1115 regarding the care coordination and transition management. Not a very long section, and much of it is common sense as well. For example, these patients should be taught to report abdominal pain, nausea, vomiting, black tarry stools, and weakness or dizziness. So just go ahead and read that section. Also read page 1115, chart 55.5, or for patients with ulcer disease for the home care focused assessment.